Bonjour. Hi, I'm Anne Lagacé Dowson of the Canadian Health Coalition. Welcome, everybody. It's great to have you here with us today. Bienvenue à toutes et à tous. Ce webinaire se déroulera en anglais, mais vous pourrez poser des questions en français dans le Q&A. I'm speaking to you from Jojage, or Montreal, the unceded territory of the Ganyankahaka people of the Haudenosaunee, or the Mohawks of the Six Nations Confederacy. And we're here to talk about the Canada Health Act. On June 13th, the latest Canada Health Act report was tabled in Parliament, covering 2023-2024. And that's what we're going to hear about from Jennifer Goodyer, Executive Director of the Canada Health Act Division at Health Canada, and Lee Whitman, Assistant Director of Compliance and Interpretation at Health Canada. And they join us now from Ottawa, and they've prepared a presentation for us. So I'll just hand it over to you, Lee and Jen. Welcome.
Thanks, Anne. So as always, a big thanks to the whole CHC team for the invite to chat with you today. We are always happy to talk about the Canada Health Act and to engage with folks who are as invested in Medicare, I think, as we are. We'd also like to acknowledge that we're speaking to you today from the unceded, uncertain territory of the Anishinaabe Algonquin Nation. Lee and I, we both live, work, and play here, and we very much enjoy our view of the Ottawa River from our offices at Tunney's Pasture. Particularly now as summer's kind of exploded onto the scene, although I would say I think we're enjoying a bit more today now that the heat dome has kind of moved on a little bit. It's not quite as oppressive as it has been for the past couple of days. So as Anne said, we do have a few slides to run through, but don't worry, we're going to be quite brief on the slides so we can save lots of time for questions. And I know Anne's got lots that she's going to pepper us with. So I think with that, we could probably move on to the next slide. All right, so this is what we're here to talk to you about today, the 2023-2024 Canada Health Act Annual Report. So this report is a federal obligation for the Minister of Health to table every single year in Parliament. And the Act technically also obligates the Minister to table this report within the first 15 sitting days, which normally puts us around kind of mid-February. So we kind of think of it as like a Valentine's Day gift to Medicare. However, this year, with the government proroguing and the election, the first 15 sitting days ended up being kind of mid-June. So as Anne said, instead of a Valentine's Day gift this year, we tabled it on Friday the 13th. So it was an interesting date this year. And I think that's actually, I know it is the very latest that we've ever tabled this report. Also, kind of a fun fact, the report is actually one of the highest accessed web pages on the Canada Health Act or the Health Canada website. And I don't think it's just our small team from the Canada Health Act Division that's accessing it, although we do access the report frequently because it's a key reference document for us. But it might also be some of the folks that are on the line today checking out the report, which is great. And I also know that the Canadian Health Coalition posts links to the report on their websites as well, so which is helpful and helps drive traffic to look at the report, because it's a really important report for Canadians to see how their healthcare systems are adhering to the Canada Health Act. And I should note that while it's a federal obligation, I can't stress enough that the report's actually, very much a collaborative effort as well between our provincial and territorial colleagues. The report takes months and months of compilation. There's lots of editing, designing, translating. And this year's report I think it's 430 some odd pages, and that's in English. The French one's longer. You can imagine it's a huge amount of work that goes into it. And so Jess Holmes, who's running our slides today, she's actually the lead analyst that does this kind of key stellar job for us each year on this report. And while we just tabled this one essentially like 2 weeks ago, Jess has already kind of hit the ground running, and we are about to launch the new cycle of the report with the provinces and territories. So hopefully that one will be tabled on time in February. You'll have a chance to look at the next annual report fairly soon. So with that, Jess, we can go on to slide 3. So again, this slide's really just to give you a kind of quick overview of the CHA. This audience is already very, very well informed and engaged, so I don't think I need to linger here on this slide for too long. But we have pulled out a couple of our key infographics for the report. The one kind of walks through the key principles, the criteria, the conditions of the Act, and the other one's kind of walking through what constitutes a patient charge underneath the Act. So as this group knows, the provinces and territories have the primary jurisdiction in healthcare administration and delivery. And this includes setting their own priorities, administering their healthcare budgets, managing their resources. But the Canada Health Act is really a prime example of the federal government using its spending power to kind of set these national standards in an area that is provincial and territorial jurisdiction. The CHA technically is voluntary, The provinces and territories participate at their own discretion, but they need to meet those criteria and conditions if they want to qualify for their full Canada Health transfer payment. And then something that we always try to stress and note, because it's something that it's a bit of a nuance that not everyone always gets, these principles apply at the level of the provincial or territorial public health care insurance plan. They're also intentionally broad because we can't encroach on provincial or territorial jurisdiction. And so those PT healthcare insurance plans and their legislation and their regulations, they not only require or mirror the requirements of the Canada Health Act, they oftentimes kind of exceed those requirements as well. We can head on to the next slide, Jess. So our division, the CHA, or the Canada Health Act Division, or CHAD, as we call ourselves, is tasked with administering the Act. We are a very small, but what we call mighty team. We have two different sides of the shop. We've got our policy unit and the compliance unit, which is headed up by Lee, who I'll turn to shortly. So as I mentioned, the Act applies to those provincial and territorial healthcare insurance plans, which means it's not directly applicable to individuals or providers of insured health services. Something else the Act does not do, it doesn't give Health Canada any direct powers to investigate or audit. So as a result of that, in administering the Act, we have to do a lot, and I mean a lot, of consulting directly with provinces and territories, and we rely heavily on their cooperation to address potential issues when they do arise. And I would say the majority of these issues really are resolved through discussions and consultations and kind of doing investigations the provinces do for us or for themselves. And it's when we don't come to those resolutions that we then move to encourage compliance with the Act through deductions and reimbursements to the Canada Health transfer payments of a province or territory. That said, the goal of the Act is not to levy deductions, but it's really to ensure that patients are not paying for those insured healthcare services because they've already paid for those services through their tax dollars. So as I said, compliance isn't the only piece we have. So we have compliance and we have the policy side. And the policy side has a lot of consensus or collaborative work as well. So like working with the provinces and territories to determine the annual reciprocal billing rates across the country each year, which allows about $1 billion worth of billing of services back and forth between the provinces so that residents have services when they're outside of their home province. The policy shop's also constantly involved in various files that could implicate coverage for healthcare services. And there's also a lot of kind of policy foresight work that they do, kind of looking down the pipe of what are the next issues we see that could have implications for the healthcare system and our universal healthcare system. And of course, this is also the side of the shop that develops interpretation letters, which we'll get to in a little bit. But with that, I'll pass it over to Lee.
Great. We can have the next slide, please, Jess. So I just wanted you to know that for the reporting year, the CHT transfer totals $49 billion. And that in some ways puts into perspective the fact that CHA deductions are not enormous, but they also at the same time carry kind of an iconic amount of moral suasion. No province or territory likes to be seen in the press as not upholding the principles of the Canada Health Act. And moral suasion is one of the tools that we use when we're trying to encourage compliance. But getting to the 23-24 deductions, you'll see that $79 million was deducted, and the majority of that was under the diagnostic services policy, which I think most people here will know came into effect in 2018, or was announced in 2018, came into effect in 2020. And so deductions initially under that policy have been quite large, but the good news is that they're going down over time, and you'll see that reflect on the next slide, because provinces and territories are moving into compliance with that policy. So 72 million for diagnostics and 7 million for other services, totaling 79 million. But there were also significant reimbursements in the period that were $90 million. The slide here will let you know that at that point, in 23-24, that reimbursements had totaled 175 million, but there were 90 million just in that year. And that's reflective of the fact that PTs are improving access for their patients by eliminating patient fees. So you can go to the next slide, Jess, because I think even though the annual report reported on the 23-24 year, I think people on this call are also interested in what happened this year. And so this year, our deductions were 62 million and reimbursements were 51 million. And the reimbursements seem a little bit lower, but that's just because the previous year there were multiple years under the reimbursement policy to refund. And this year there's just the one for diagnostics. And you'll see that the CHT grew to 52 billion for the year. So, you know, the federal investment in healthcare, while it doesn't cover the entirety of healthcare costs, is a significant portion. And the investment is safeguarded, I think it's fair to say, by the principles of the CHA and provincial efforts to meet those requirements. Go ahead, Jess. Jen's going to talk about the services policy soon. Jen has already covered this, and so I'm just going to skim over it, except explain that when I speak of the reimbursement policy, this is a policy that was announced in 2018, and it means that if a province or territory is subject to a deduction owing to patient charges, they can have that money restored to their healthcare funding if they take action to eliminate those patient charges within a couple of years, and they eliminate the circumstances that led to them. And so a very contemporary example of that would be abortion in New Brunswick, let's say. The government of New Brunswick eliminated regulation that prohibited coverage of abortions except in hospital. And we have been deducting New Brunswick for a number of years. But with that, that circumstance that led to the deduction eliminated and the patient charges stopped, we were able to issue a full reimbursement to them. And there have been other provinces who've received full reimbursements as well, including Manitoba for diagnostic services and Nova Scotia for the same. You go ahead, Jess. So before we continue, I just, whenever we have new staff or we do presentations for stakeholders, we like to talk about myths that exist under the Canada Health Act, and it's perhaps clarifying for the Q&A portion. But one thing that we read in the media still is that the public administration criterion forbids private involvement in insured services. And this has never been true under the Canada Health Act. And there are lots of elements of the public healthcare system that are delivered privately. Physicians are independent contractors, if you will. Hospitals can be run, and many of them in Canada are, by private foundations, or support services can be outsourced. And so what you need to keep in mind is that delivery can be privately owned or privately run, so long as patients are not charged for those services. And so that's when CHA concerns arise, and that's when we start to take notice and start talking with our provincial and territorial colleagues. And another thing that we see in our media clips every day is, you know, this specific condition or treatment is insured under the Act. But the Act is broad, and it's intentionally broad because the jurisdiction for healthcare rests with provinces and territories. What we can do is provide a framework for provinces and territories to receive their full Canada Health Transfer payments by meeting the broad conditions under the Act. And so it is not nearly so prescriptive as to drill down to specific ailments or conditions. And we've also in the report announced and described the new CHA services policy, but I'm going to turn it back to Jen to talk about that.
So yeah, I think technically you could argue that this falls out of the reporting period that we were putting forward in the report for 23-24, but technically we were also working on this latest CHA interpretation letter for quite some time, and during this whole reporting time frame as well. So the report does make mention that our former minister did issue the latest CHA interpretation letter, the CHA services policy, on January 9th of this year. And I think, again, I think we've talked about this in previous CHC discussions. You know, as healthcare has evolved in the past, various federal ministers of health have issued clarifications on provincial and territorial counterparts. And these letters kind of really help ensure the Act keeps pace with the modern realities of healthcare delivery. But one thing they cannot do is they can't expand the original intent or scope of the Act. That would require an amendment to the Act. So just as we did for the kind of clinics policy interpretation letter back in 1995 and the diagnostics policy interpretation letter in 2018, both of those essentially said that insured services should be covered regardless of where they're being provided, whether it be in a hospital or in a clinic. This policy says that while we're very much in support of expanded scopes of practice for regulated health professionals like nurse practitioners or midwives as a way to increase access to care, a much needed increase to access to care, which is such a huge issue for our healthcare system at the moment. These expanded scopes of practice should not result in patients being charged when they're receiving insured services from these regulated healthcare professionals. And so that policy comes into effect on April 1st, 2026. We're working with the provinces and territories on the implementation of it now. But as of April 1st, 2026, if a patient does access an insured service from a regulated healthcare professional, like a nurse practitioner, it will be considered extra billing and user charges under the Canada Health Act. And I think with that, we can move on to the last slide, which I believe goes back to Anne for questions.
Okay, so thank you very much for that. That was pretty succinct. I thought the myth-busting part was particularly interesting. And I would invite those of you who might have questions or comments to jump on the Q&A and add anything that you would like us to address through the Q&A, and then I will pass them on in the context of this webinar. So thank you very much to Jen and to Lee and to Jessica for moving through those slides so quickly. I would just mention that the actual report itself must be easily 1.25 inches thick and is quite impressive document. And that's just the English version. And that the report, as was mentioned, comes out every year. So we thought at the Canadian Health Coalition that it would be worthy of scrutiny through the webinar. Maybe we need to make this an annual event, but I would invite those of you who are activists or who have questions about the Act, about the money that is held back, the money that has been restored in each of your jurisdictions, because I know there's lots of irritants and we hear from people about them at the coalition. So I'm going to start by asking both of you, what is different, I guess, about what you told us about this year and past years? Like, is it possible to see trends or sort of overall trends from the provinces and the territories, which is what PT stands for, provinces and territories? I'll go to you, Lee, because you're the compliance guy. Kind of like the
Sure. Yeah. Well, I think that what's the trend right now is that deductions are going down, and that actually is a good news story. I know that there could be a temptation to think, well, you must be going softer on them. But the reason deductions are going down overall is that provinces are coming into compliance with the diagnostic services policy and, and other issues. So I would say that's the trend. The other, I think, really powerful good news story is that the reimbursement action plans, so that's part of the reimbursement policy I was telling you about, are working. And so if a province or territory completely eliminates patient charges for which they've been deducted, as I said, they can get a full reimbursement. But we also can give them partial reimbursement if they're making significant progress toward that goal. And you can read about those in the annexes of the annual report. You can see the plans that provinces have set up to eliminate patient charges and how they're following through, because they provide updates to them every year.
And I wonder, there have been a lot of stories about patients finding it ridiculous to be upsold and billed for cataract surgery. This has been an irritant across the country amongst members of the coalition, from PEI right through, especially also in Ontario. I wonder if you can talk a little bit about the specific concerns
Sure.
about cataracts.
Yeah, I think that it is fair to say that, excuse me, that patients are being upsold. They're being offered, lens B over lens A because, it does wondrous things and, yada, yada, yada. We would be very concerned if a patient was required to buy a lens that was better than the preferred one as a condition of receiving treatment. That is just a non-starter under the Canada Health Act. And if we had a letter from a patient, we would certainly take action on that. Upselling itself is fine in terms of the Canada Health Act. And I really want to draw a line down between what is maybe shady behavior, which should be addressed by the college or the PT Health Ministry, and what is okay under the Canada Health Act. And, we're concerned about patient charges for insured services. And so again, if I went to the hospital and I was told, well, OHIP will cover a plaster cast, but if you want this really lovely fiberglass cast that you can take off and bathe more easily, and it's $150. That's a fair offer. We can debate the ethics of it. But if I'm required to buy that in order to receive the insured service, then no, that's not okay. And so I guess I should say that in terms of making a complaint under Medicare, people certainly should write to the provincial health ministry if they have a complaint, if they have any sort of whiff of, I've been subject to a patient charge. And we provide the contact information on our website and in the report for all of the provincial Ontario. I apologize for saying PT. There's something in the coffee in the Brook Laxton building that makes you speak in acronyms. Um, but so the first thing would be to write to the provincial ministry, because sometimes these are an issue of education. A provider has, honestly charged a fee they shouldn't have, and so they need to be educated and they need to refund the fee. Sometimes it's a misunderstanding that a person thought something was insured under Medicare that wasn't. And there are certainly other avenues as well. They can speak to the college because they feel that if a physician has been unethical with them. They can, in many provinces, speak to the ombudsman if they're unhappy about the decision the ministry has made. But they can also write to us, and we're very happy and open to helping people with these sorts of things. But the first thing we will tell them is that you need to write to the provincial ministry because it's their jurisdiction to deliver healthcare. And it's really only when we would disagree with their assessment of whether a patient charge was permitted or not that, we begin to intervene. And that may involve getting consent from the patient to share the details of their encounter, and really interacting with the province or territory involved. But I will say that, and I know I'm getting to be a bit long-winded here, PTs share our goal of making sure there are no patient charges by and large. And so most often when we write to them to say, hey, we read about this in the media or somebody's written to us about this, they're already well down the road of ending that patient charge.
I wonder, we've heard a lot of this kind of comment from many of our supporters and even amongst the staff. I mean, so extra billing is still happening while some governments claim that it's not. This is I'm picking up on a comment from Ivan Stephen. Why is the federal government not enforcing the act? It seems to me, says Ivan Stephen, that increasing deductions is not something about which the Ontario government is concerned when they are focused on downloading fees to users. And I think that is a feeling that is shared by a lot of people across the country. I wonder what you would say to that.
I'd want a more specific example of what downloading fees to users was, but I think that our interaction with the Ontario government is that the commitment to the Future of Medicare Act is a pretty solid piece of legislation, and they're pretty active at enforcing it. But yeah, I think, and this is probably a great lesson for all of us, is sort of broad statements about the healthcare system are great for advocacy, but in terms of intervening with PT health ministries, specific examples and why they would violate the Canada Health Act or the commitment to the Future of Medicare Act are important. I'm going to turn to Jen because I see she's gone off mute.
I was trying to do it a couple of times, but then I was like, you kept covering things I was going to mention. But I would say, like, I think again, in these kind of like the complaint mechanisms and things that we do have. Provinces and territories have their own complaint mechanisms as well. And then we've put up our kind of our Medicare address here. And even recently to this Medicare address, the Ontario Health Coalition wrote to us, and I think was also did an open letter. And I think there's some articles in the Toronto Star, part of it talking about the upselling of cataract surgeries and the concerns with that. But what's helpful with when we have these kind of things is they've also provided us with invoices to go through. So both us and the Ontario Ministry have, now we can go through it together and kind of look through these things, determine what is or is not a patient charge. And then we can work through it together because we actually do have documentation to then examine. And so we've in this case, we automatically sent a note to our colleagues in Ontario. They're like, yes, we have the same package of documents. We're going to look through it, and then we'll meet together, once we've all had a chance to go through the fairly large package that we received from the Ontario Health Coalition to kind of determine, are there some concerns here? Is it upselling, which is kind of, as Lee says, I would say an ethical gray area. Obviously, it's not something that we like, but we can't do anything about it in the Canada Health Act. But is it something that maybe the colleges should be looking at in terms of ethical behavior? Is it okay to go in for, one cataract and say, you can have the other one done in like 3 weeks time if you come in and pay for it, or you can wait a whole other year. So it's, you're fairly vulnerable in that situation as a patient when you're talking about your eyes, right? So I think it's those ethical gray areas that are concerning, but we also, there's some limits to what we can do about it.
There's a question here from Gail Davey, who's asking about something that we as at the staff of the Canadian Health Coalition wanted to address, which is the issue of vaccines. The Alberta government has apparently decided to charge people for vaccines, which it seems to us have been at least partially covered by federal transfers. So I wonder if we can address that issue. I'm talking about COVID vaccines, but presumably it also involves other vaccines.
Do you want me to take that one, Lee?
Sure, yeah. This is going to sound like I'm sidestepping the question, and I promise you I'm not. Vaccines aren't an insured service under provincial healthcare plans in general. They are a public health measure that provinces and territories take. I'm very much in favor of that measure. But they're a public health measure that is usually administered municipally, but it can be on a province-wide basis. But it's not in general an insured service under any provincial or territorial healthcare plan that I'm aware of. But I will encourage everybody here to get their vaccines.
And so those people who feel that they're being unfairly charged for vaccines should address themselves to the Alberta Health Ministry, is what I guess is.
Yes.
Yeah.
And then they could also contact, you mentioned the College of Physicians, the Ombudsman, and then eventually write to you. That's the way that.
Yeah. Although our answer to them, frankly, will be that it's not an insured service, so it doesn't get captured under the Canada Health Act. We can, because I think Jen mentioned earlier that the requirements of the Canada Health Act apply to provincial and territorial healthcare plans. I'm sure you've read the act, and it really does talk about, the plans. Provinces must provide a plan that does this, that does that. The plan may not permit this, permit that. And so we can only capture things that happen under the orbit of a provincial or territorial healthcare plan.
So childhood vaccines are not covered either, presumably.
No,
Okay.
not in general.
Okay.
They're in the world of public health.
And just to note, that's when I was saying, the provincial and territorial healthcare plans, they do mirror the Canada Health Act, but in many cases, what's provided in terms of healthcare in a province goes way beyond what is required in the Canada Health Act. So there's a number of services, we refer to them as additional benefits, that can be provided to residents of a province that are beyond the bounds of the Canada Health Act.
I wanted to get to the whole issue of nurse practitioners. This is something that was mentioned in a most recent letter from the minister. Let's talk about the nurse practitioners, because obviously they operate in different settings. This is a comment from Jordan Jarvis. Executive health clinics, retirement homes, in-home and mobile care, etc. Does the new CHA services policy apply across all of those settings for nurse practitioners? And then I'd like to talk a little bit about the letters that come from the ministers over time and how they interact with the Act. So let's talk about nurse practitioners and then about the letters. I don't know who is.
Yep, I'll take that one. Yep. So with the CHA services policy, which does scope in nurse practitioners, it's not just about nurse practitioners. It's about kind of any regulated healthcare professional where it does have that kind of overlapping scope on that kind of that Venn diagram that I showed. It just happens that nurse practitioners right now, their scope of practice has expanded so much, which is fantastic, that in some cases they can be providing up to 80% of the same services that a general practitioner might be providing in terms of primary care service to a resident. And they are like nurse practitioners are like in many different venues across the healthcare system. So what the services policy is trying to capture is if those nurse practitioners are providing what would have been provided and covered by a physician, say when the Act first came into being in 1984, if those services are now being provided by a nurse practitioner, they should be covered by the provincial or territorial healthcare insurance plan. So it can't be everything that a nurse practitioner is providing because there's some uninsured services, the same as physicians. Physicians, not all their services are covered by a healthcare plan or by the Canada Health Act, but it's when it's a service that say like, even 10 years ago, if I went to my doctor and it was covered, if I'm now going to a nurse practitioner, I shouldn't have to pay for that exact same service. So that's why it's really refers to this kind of physician equivalent service. It's not the CHA like nurse practitioners policy, it's the services policy. So it's really hinged on those insured services, which are part of the kind of that core basket of services under the Canada Health Act, which kind of on that Venn diagram you see are like, diagnosing, treating, referrals, prescription medication, like actually prescribing of it, ordering tests, as things that really are in the gambit of the essentially primary care services. Or in cases where nurse practitioners or even surgeries, those I think in every case those are covered if they're working in hospitals already.
And can provinces legally restrict nurse practitioners from charging for services that they themselves?
Oh, charging, that's what this is supposed to help with. But it's the provinces and territories that have the ability to expand the scope, right? We can't say you have to expand the scope of a nurse practitioner in your province. That's up to the province or territory. I think most have expanded scopes of practice across the country. I think they recognize this is a huge resource. We've looked at certain modeling of where the healthcare system could be in like 10 years out in terms of our health workforce. And we're still like at an undersupply for physicians, but there might be a bit of an uptick for nurse practitioners. So this also could help us address that access to care gap that we're all experiencing in our healthcare system. And this is a group of professionals that have phenomenal health outcomes. They want to be able to treat patients within the publicly funded healthcare system. And this letter kind of enables the provinces to be able to make sure they fully integrate them into the healthcare system. So the publicly funded one.
So for those who are not, the letters of instruction from the minister effectively clarify and in certain senses enlarge, it seems to me as an outsider, the scope of the act. I wonder if we could talk a little bit about the history of letters of instruction and what role they play in terms of the ways in which they impact the act and the way the impact they have on services to Canadian citizens and taxpayers.
So sure. So the interpretation letters in general can't expand that basket of service. That would require an amendment to the Canada Health Act. So really all it can do is clarify the intent of the CHA and how we mean to administer it. It's a policy letter. It's not a legislative piece. That being said, the last three interpretation letters, I would say, are our reimbursement policy, diagnostic policy, and the clinics policy. Those have informed deductions over the last couple of decades. So they are what we use to interpret the act and really to kind of keep the act modern so that we are trying to keep it at pace with healthcare delivery. So when in the mid 90s, at that point, a lot of some surgeries were moving outside of hospital, and then they weren't underneath that big H building anymore. And so the clinics policy at that time meant to address that kind of migration outside of the hospital for some surgical services, which were then being charged to patients. Where like you can't just move it outside the big H hospital and then expect people to pay. That's not okay. Those services were insured to start with. Same with the diagnostic services policy. Once you have technology that was able to move those MRIs or CT scans outside of a hospital into clinics, that doesn't mean you should walk up to a clinic and skip the queue. That's not okay. Those are insured services. You have a physician requisition for an MRI or a CT. They should be covered by the provincial or territorial healthcare plan. So it doesn't matter where you're getting that insured service. This new one, it's not really talking about the where, it's kind of the who, who's providing that service to you. But it's all about that service. It's that original basket of insured services. So if it was meant to be covered in the first place, it should still be covered. we don't want to see an erosion of the, the basket of care just because technology is moving forward like in leaps and bounds.
There is currently a new health minister, Marjorie Michel, the member of parliament for Papineau. And it's not clear whether or not she has much experience in health. So what role or influence does the minister have in interpreting and administering the act? Like we've seen Mark Holland most recently take action with a letter of interpretation, which I call a letter of instruction. But so what is the role of the minister with regard to the act?
Well, it's the minister's responsibility. So the act is, so we have essentially, like, we work for the minister, obviously, and we will put up forward recommendations to the minister, but it's the minister's obligation to uphold the Canada Health Act. And so and it's also the minister has the authority to interpret the act as she sees fit. So it is something that the minister has the ability to do. It's how the minister sees the act being interpreted is something that the minister could issue an interpretation letter on. I would like to say that we don't issue that many of them. They honestly take a lot of, we don't want to kind of water down the effect that an interpretation letter would have. There's only been 4 in the entire course of, since the act came into being in 1984. And the first one just kind of came out to kind of really clarify what we meant by how we were going to administer the act. And that came out in 1985. So this is only kind of the 3rd one since then, in terms of what a minister means, in terms of how do we keep the act, keep pace of how we administer the act with how healthcare is actually working on the ground.
I think a lot of us who have observed what's been happening with healthcare would really like to see more of I don't know, some kind of enforcement, or would like to see more done to keep the provinces in line, because in places like Alberta and Quebec, we see extreme amounts of privatization. In Alberta, hospital ownership has been practically legally privatized by the current government. In Quebec, we see all kinds of diagnostic tests and a pressure to push people into the private sector. We have 800 doctors who have completely, and I mean completely, opted out of healthcare. And I wonder how those things are viewed by staff at Health Canada, and presumably eventually by the minister as well.
So maybe I'll talk about the Quebec piece and then punt over the Alberta one just to save my voice over to Lee because I need a sip of water. But so yes, Quebec I would say is a bit of a unique situation in terms of the number of physicians that have opted out. I think it's 880 perhaps now at this point. And that's a fairly stark comparison to the rest of the country, which is about 12 across the rest of the entire, Canada. So it is a very different system in Quebec, I would say, that they have this ability to kind of opt in and out at a more frequent level. Although Quebec does have tools to kind of limit that, non-participation if they deem access to be at risk. So if they think a threshold has been breached and they're seeing concerns about their healthcare system, Quebec legislation does allow them to kind of, try to put some ring fences around those doctors to draw them back into the public system. And I do think you're seeing some movement in Quebec to kind of control some of these, opting in, opting out physicians, as well as just kind of some concerns about physicians not participating in the public system.
The answer of the Quebec government to queries on this is that this is part of the law. Quebec was the last province to join healthcare, and it left a 3rd category, and basically a loophole in provincial regulatory and legal, the legal structure of healthcare. And that's why we don't see it in English Canada, but we see it in Quebec. And they basically just sidestep it, and they act all surprised when people are upset by it. And I'm saying that from firsthand experience, because I was one of the people who spoke to the health committee in the National Assembly not too long ago on this issue. I don't know if inside.
Well, I think it's fair to say, though, Anne, that Quebec has shown perhaps a different line of thought lately, with Bill, is it 83 or 93? 83, I think. They're going to obligate physicians to work in the public system for 5 years. And if they don't, the penalties are significant. And physicians have to, if they want to become non-participating now, there's an approval process for that takes into account local needs. Now, this is all really new, but we'll see how that affects levels of non-participation. In my view, in the past, the key problem wasn't that, or simply that physicians could become non-participating. It was that they could move in and out of the public healthcare system monthly if they wanted to. Whereas
Really?
in other well, it was 30 days. So, but in other provinces where it was allowed, if you elected to do it, you had to stay out for a year. And so, you really, I think, had to have a serious conversation with yourself about what that decision would mean for your career and your hospital privileges and all sorts of things. So I'm optimistic, and I'm yeah, I think they're heading in the right direction, and there'll be pushback. I think I Quebecers have a great sense of autonomy, and that would include doctors. And so to be told that, these are the new rules and you have to play by them, we'll see.
Just switching topics now, what's been done by Health Canada in terms of eligibility of undocumented migrants overall? This has been a concern at the Canadian Health Coalition. My colleague Tracy Glynn has been very active on this file. I wonder if you can just give us the latest thinking with regard to people who fall into this category.
Yeah,
Migrants, even those who are documented, who have difficulty accessing healthcare.
yeah, you might be asking the wrong people. I mean, we're talking about the Canada Health Act here. In order to qualify as an insured person under the Canada Health Act, you have to be a resident of a province or territory. And there are really just three questions to answer on whether or not you're a resident. Is you have to be ordinarily present in the province or territory, you have to be there legally, and you have to be allowed to remain legally. Um, and so I think for non-documented people, that's probably not going to be the right fit. And so the real question I think would be addressed to Immigration Canada about, on what basis are they staying? What permits do they have? Do they have how quickly can they get work permits and in some cases achieve PT coverage? But it's really not a question under the Canada Health Act because it's a little more mainstream than that, I guess I'd say.
And here's a question that actually passed through my mind during the presentation. What percentage of PT healthcare costs are covered by CHA transfers? Because at initiation, it was supposed to be 50%. This is from Ed Ellis. Like, what is the breakdown between the
Yeah.
fed and the PT?
Well, it depends who you ask, right?
Yeah.
It depends which economists you ask, but what I think in this building would be an agreed upon number is 20 to 25%. There was a time that it was 50-50 cost sharing. That's correct. But there was a point in the 70s where the federal government wanted to have predictable levels of funding, I think was the polite term at the time. And so it shifted from 50-50, which frankly, from my view, I'm a Nova Scotian originally, that favored richer provinces because if the federal government was going to pony up 50% to whatever the province would bring, it isn't equitable, I don't think. So it went to I think it was the EPF, the Established Programs Financing, and then some tax points were devolved to PT so they could collect or have fund healthcare themselves, and then here we are. But the answer to your question is 20 or 25%.
Here's a question from a beloved member of the board of the Canadian Health Coalition, Dr. Joel Exton, and he says he's asking, does Health Canada wait for complaints about violations of the CHA, or do you have proactive investigations to ensure that the act is being respected or followed?
So maybe I'll take that one firstly to give you a break from your
Yeah.
voice now. So we can't just go on a complaints-based model, and we stress that with our provincial and territorial colleagues as well. You can't just wait for complaints because I don't think it would work that way. Partly because some people are quite happy to try to pay and jump the queue. And there are other issues where someone might not flag a complaint about being charged for something. So, in recent years, Ontario has been taking deductions for access to abortion services. They had received no complaints about those clinics charging patients formally. They had received no formal complaints. We had seen some, we monitor a bunch of different things through our compliance side, whether we're looking at, social media pages, like random like news articles.
Oh, we've
I
lost.
think Jen's sound has crackled out, so I'm going to speak over her, which is the only time I'm allowed to do it. So yeah,
After
my
an
team.
abortion.
Sorry,
Oh,
Jen, sorry to interrupt, but your voice cut out for a good long chunk of time there, about
oh,
7 or 8 seconds at least. So I wonder if you would like to let Lee reprise, or do you want to reprise and hope for the best? See, you've
I
cut
think
out.
we'll take that as,
Yeah, sorry. We're gonna let Lee pick it up, Jen. Sorry about that. Go
yeah,
ahead.
that's all right. So what she was alluding to was the fact that there were some community clinics in Ontario that were providing abortion services, and there were no complaints about them, but we became aware of them through media, through social media. And we reached out to Ontario to start the process of looking into that. We also hear directly from PTs, it might surprise you to know, to say, hey, we're thinking of doing this. We're thinking of rearranging our healthcare system or the way we deliver this or that service. And are you going to be okay with that? We've had PTs write to us to say a set of doctors is thinking of setting up this or that clinic. Would you be okay with patient fees for this or that? And I think it might surprise you to know sometimes they're doing that so that they can then go back to providers and say, listen, the federal government is not okay with this. We're going to get dinged if you do it. And it's again sort of a what feels, I think, like a big hammer, and it helps them to get clarity from us from the get-go.
Did you want to jump back in, Jen? I think maybe your sound is better now.
yeah, I got dropped off the call, so I had to rejoin. So I'm not sure where we were in that question in terms of responding. Do you want to give me a
We were
synopsis,
talking
Lee?
about advanced assessments and the fact that we're proactive as well when we see things in the media, social media, and elsewhere.
Okay, and so the one piece I was talking about was the abortion clinics in Ontario.
Yeah.
Did you? Okay, we got through that part.
Yes.
Okay,
That,
so
yeah.
I was just noting that we didn't have any formal complaints, and nor did Ontario on that. But having heard some rumors of charges at those clinics, we did dig a little deeper, and that's where we didn't accept a no formal complaints response. I guess, from Ontario, and that we recognized there was a bit of a structural issue with some of those abortion clinics not doing a good job of advertising to patients that you did not have to pay for certain services to receive the abortion. So they've done a better job of trying to work through that, and they're looking at legislative changes in Ontario to deal with that issue, I guess. So I think just relying on complaints doesn't work for either us or for the provinces or territories.
Here's an interesting question from Jill Swan Lucia. She says, she's asking, can provinces interpret what medically necessary means?
It's actually up to the provinces and territories to do just that. We don't get to do that. That's a provincial role.
And do you ever intervene,
Yeah, and
disagree with them with regard to what's considered medically necessary?
I would say the closest we would be with the diagnostic services policy when there was, I would say yes, a disagreement. So there was provinces allowing for payment when diagnostics were provided outside hospital in private clinics. And that policy is essentially saying you cannot do that if you have a physician requisition for a MRI or CT, regardless of where that service is provided. It's deemed medically necessary and should be covered by the provincial or territorial plan.
yeah, and I just like to stress that medically necessary in the sense that we use that phrase is somewhat technical. It does not encompass every single thing that your doctor thinks you might benefit from. It's services that have been discussed between the medical profession and the plan and have then become insured.
Okay. I'm trying to sift through it. There's a number of very articulate, kind of long-winded comments and questions in the Q&A, but I wondered if you could tell us, once you've received a complaint and deem it legit, what's the process that you then undertake?
Well, when we receive a complaint, we do an initial assessment because sometimes somebody is complaining, I don't like that a private company is delivering this insured service and no, I'm not being charged for it. And so we would write back to them and let them know that wasn't a CHA issue. But we do sort of a triage, does this look like a patient charge? And then we reach out to the province or territory and we lay out the facts as we know them and ask them to look into it. And we wait to hear back from them and that will initiate a dialogue between us and the province or territory where they will clarify, no, there's been a misunderstanding or there needs to be a bit of education or, there was patient charge, we've stopped it. And then on the very rare occasion, frankly, it will be that they are fine with the patient charge. They have a disagreement with us. And that's when we have to elevate things a bit up the line. So an example of that would be that in Saskatchewan, um, they allow patients to purchase diagnostic imaging from private clinics, and they allow clinics to charge patients for those things so long as they provide one of equal value to somebody in the public queue. So that's a great bit of optics, but it also still, is charging patients. It allows those with means to jump ahead of others, and it's pulling health human resources from the public healthcare system. So that's when we start talking at higher and higher levels and start considering penalties. And Saskatchewan is currently being penalized for that.
Somebody writing from Alberta saying they're concerned with the current government's Bill 55. What does that mean for access to reproductive health care, including abortion, gender affirming care, and access to MAID? Have there been any directions issued to the PTs that hospitals run by religious organizations, including the Covenant organization, which is one that I'm a bit familiar with, have to provide a full range of reproductive health care, gender affirming care, and MAID, regardless of the religious beliefs of the people who run the hospital?
Well, no, the answer to that is no. Where we would be watching to make sure that that accessibility to services is still there. We don't do things like that preemptively. We have relations to try and preserve. Um, but no, the answer is no, that we haven't. But we also haven't seen yet, somebody being told, no, you may not have that service at this hospital anymore. So.
What if a PT refuses to comply or assist with an investigation that you come to them with? Has that ever happened? And what if it does?
Yeah. Did you want to speak, Jen?
Sure. So in that case, and I think one of the things we didn't touch on per se going through this, well, we work collaboratively with the provinces and territories on the CHA annual report. This is only one of our reporting mechanisms. We have a legislative requirement for provinces and territories to report into us each year on the amount of extra billing and user charges that occur every December. They have to submit those reports to our Deputy Minister of Health. If for some reason we are aware of patient charges in a province and we receive the report and it says zero, we then have an obligation, or the minister has an obligation under the Canada Health Act, to estimate what we think the scale of patient charges are in that province. And so we have to use the best available information to determine what we think what that dollar amount looks like. And then we have to, the minister has an obligation then to consult with the province so they could, provide us with their own information should they see fit. And if they don't, that's the amount that we deduct from their plan or from their CHT.
Question from Dennis Kendall. Are all services provided by nurse practitioners publicly insured and covered by the CHA? And I'm going to add another question with that from Nicole Corrado, who wants to know when mental health care will be covered, because there seems to be a growing consensus that there is a grave mental health care crisis across the country. So 2 questions there.
Yeah. Well, sorry, can you reread the nurse practitioner side of it?
This is from Dennis Kendall, who I believe is a physician in Saskatchewan, if I'm not mistaken. Are all services provided by NPs, nurse practitioners, publicly insured and covered by the CHA? And the other question was with regard to mental health care and the feeling that more needs to be done.
So the answer to the first question is no. And that's because not all services that are provided by physicians are covered either. It's only those that would match insured services provided by physicians. So for instance, if you go to your doctor's office because you want to join a gym and you need him to fill out a form, that's not covered. In the same way, those services provided by a nurse practitioner wouldn't be covered. In terms of mental health, the hospital and physician portion of mental health services, and I understand that they're not the entirety of that world, are covered already under the Canada Health Act. But in terms of when the act might be amended or how, it would be guessing, and I'd be speculating.
Because my sense is that is really especially with regard to younger Canadians, that is the feeling is that that's a pressing issue that not enough is being done about. So to those people who are activists on this front, what would you suggest?
Well, there are targeted funding mechanisms that are being directed at mental health and particularly at youth. And, I would encourage them to express their support for those sorts of things. But what I would always say to somebody who's unhappy with the way the system is working is to write to your MP, write to your prime minister or your minister of health, and express what you think would make the system better. Because I think, it would surprise people to know how closely those letters are read and counted and taken quite seriously.
Here's a question from an anonymous attendee. If a province chooses, no, exactly. An anonymous attendee wants to know if a province chooses not to cover a physician equivalent service provided by a nurse practitioner, pharmacist, or midwife, are individual providers expected to self-report or restrict offering those services, even when they are deemed to be medically necessary? So a lot of questions about nurse practitioners, I guess, because they're the newest group to enter the scene.
And I would say, I know for some reason I keep getting kicked off, so I apologize if I keep cutting out, but those are the devils and the details that we're working through with the provinces and territories right now in terms of implementing that policy, because we do have till April 1st to kind of adjust plans to adapt to that policy. So those are some of the issues that we're working through right now.
Okay, and here's a question from Jeanette Pongratz Doyle, who wants to know, with the federal government now making driver's licenses for seniors be renewed every 2 years from every 5 years for 65-year-olds and over, it's going to increase costs for seniors. Doctors charge $150 or more for a medical. And Ms. Pongratz Doyle is saying this is outrageous for seniors living on pensions or those who do not have good pensions.
I'll take that.
Yeah, what kind of action can be taken to protect, I guess, seniors in those?
Well, I think they need to write to their provincial governments, because driver's licenses are issued provincially.
Right.
I know that in some provinces there are requirements like that. My dad happens to live in Nova Scotia. I was concerned about his driving and emailed to find out about that sort of thing, and they just trust people to know when to stop driving. So it's a provincial thing, and they need to express their displeasure that way.
Okay. From Christopher Karras, who's wondering what's going on with the privatization of Canadian blood services. Since CBS partnered with the for-profit gigantic company Grifols, is this potentially an infringement of the Act? And this is an issue that we've covered a bit at the Canadian Health Coalition, specifically the sale and collection of plasma in relatively impoverished areas. There's a lot of really murky ethical stuff going on with that.
Yeah, what you always have to remember when we're talking about the Canada Health Act is how does it touch a PT healthcare plan, and blood collection, paying for it just simply doesn't. I know that blood collection is federally regulated, but not under the Canada Health Act, so I'm not qualified to sort of address those concerns.
So who would Christopher Karras address then with this concern? Sorry, I have an anxious hat here.
Yeah, Jen, do you know?
Well, if you haven't written to Canadian Blood Services themselves, we could probably get a contact name, and I don't have a name off the top of my head.
Yeah, I would guess which branch, but I don't want to guess incorrectly, because I know this is going on YouTube, but I don't want other people to take that lead.
And I think on that note, because we're almost bang up against the clock, I'm going to draw the proceedings to a close for today. But I really am grateful to both of you for coming on and talking to us. It's sort of proving that Canada's public servants are definitely worthy of our admiration and pride, because for a long time that's really been the case, that we like to brag about the quality and caliber of our public servants. So Jennifer Goodyer, Executive Director of the Canada Health Act Division of Health Canada, and Lee Whitman, Assistant Director of Compliance and Interpretation at Health Canada, thank you so much for joining us today. We're going to have to cut off today, but I think we would like to have you back sooner than later, and hopefully we'll see you at our research symposium in the fall in Ottawa. But a big thank you to you and to all of the people on this webinar today who are clearly incredibly well informed, and I apologize to those people whose questions we didn't get to. We'll try and figure out another way to tackle some of these issues. So a big thank you to Tracy Glynn, as well as Jessica Rochon, who's been handling slides, and Tracy has been handling the logistics behind the scene. And a big thank you to all of you who fight for and believe in universal health care among our supporters of the Canadian Health Coalition. I just want to mention in closing that on July 21st and 22nd, there will be a Shadow Summit car cavalcade and mass rally outside of the Council of the Federation in Huntsville at the Deerhurst Resort. So check out the Ontario Health Coalition's webpage and sign up if you can make it up there into the beautiful area known as Muskoka on July 21st and July 22nd. So finally, just to say merci beaucoup à tous et à toutes, and thank you for participating today. We'll have more webinars coming to you, and this one is going to go up on YouTube for those people who want to go back and listen more carefully to what Lee and Jen had to say. And there's lots of other interesting material on our YouTube channel as well on healthcare issues. Merci à tous. Have a great day. Thank you very much.
Merci.
Bye, Jen. Bye, everybody.
Bye all.